Hello, Calaveras County. How are you doing? Well, I know just who to ask because the doctor is in. Dr. Randall Smart, how are you?
Hi, Mike. It's great to be here today.
And I didn't tell everyone, but I am Mike Taylor. Nice to see everyone. Now, we are in the fall of the year, and it is flu season.
That's correct.
So, step one in avoiding the flu.
Step one would be to do a lot of hand washing. Flu is, what we should really talk about, Mike, is what is not flu. What is flu and what is not flu?
Yeah, because we do a lot of our own self-diagnosis.
So everything becomes the flu. According to the patient.
Yeah.
And so influenza is different than a sore throat or a sniffles. Influenza is a serious systemic whole body viral infection that is very different than a cold.
Okay.
So not everybody with a cold has influenza. They call it flu. It's really not. But influenza is a virus that infects really your whole body. And so this is the time of year it starts to be transmitted. We could talk about that a little bit. But the transmission route for influenza is primarily air droplets.
Oh, okay.
So when you sneeze or you cough, you don't always know this, but you produce these little air droplets, and they're teeny tiny. If you ever saw somebody sneeze, like with the sun behind them, you could see a little bit of that. Guess how many virus particles are in each air droplet?
I shudder to think.
Between 100,000 and 1 million.
Oh my gosh.
Per air droplet.
Per droplet, and we're talking droplet.
And you're talking thousands per sneeze or per cough. So those air droplets are very infectious, and when they come in contact with, if you breathe them in or nasal mucosa, that's the primary way the influenza is transmitted. It also can be transmitted by touch. So if those air droplets are on a surface and you touch it and maybe scratch your ear,
you cough, and then use the doorknob,
you're in trouble. So what I tell patients to avoid it is to stay away from sick people.
As obvious as that sounds, sometimes we don't. So.
During an influenza outbreak, to be kind of cautious about when you're in public and where you go and what you do. So you might want to go to the post office at a time where most people don't go. Yeah. Or the grocery store when most people don't go.
It's not a time to go to the salad bar.
No, and it's not a time to socialize.
No.
It's just not. It's a time to take care of yourself. And I mean, even you're going to think I'm a germaphobe, and I'm really not. Well, maybe half. But you should avoid railings, touching them if you can, doorknobs, touching them if you can. Things that you normally touch, those are all contaminated.
Yeah.
And so hand washing, staying safe, staying away from the public, even to the extent you might want to have some handy wipes.
Some sanitizer.
Sanitizer handy wipes, exactly, to keep your hands clean. But those can get you a lot of mileage.
And keep you from getting it. Now, let's see. I'm trying to think of which way we want to go. We talked about what isn't the flu. How do we actually know that you do have the flu? Can you actually do a blood test or something and say, "Oh, yep, he's got influenza"?
So there are tests that can diagnose influenza. Those tests are usually like a nasal swab or sometimes a throat swab. It's usually some sort of a respiratory or nasal sample that can be tested. And that can be useful, but I'll tell you something very interesting, is the majority of these diagnoses of influenza are made by a clinician who asks the right questions. And in that scenario, that decision-making is as accurate as actual laboratory testing.
So is it kind of the process of elimination? You have this symptom, you have this symptom, you have...
Right.
Is that kind of what you're... And is that where the questions are leading the clinician?
So what I do in my practice, and I think most practitioners do, is first of all, you need to know, has the patient really been exposed to influenza?
Oh, okay.
So the way we decide that is there are maps, epidemiologic maps that show you where influenza is. And if you looked at California right now, there's no influenza in California. So if you came in today and said, Randy, I have the flu, I would say, Mike, there's no influenza in California.
Yeah.
However, have you been traveling? Have you been out to Georgia or South Carolina where they are seeing flu now?
Okay.
Or have you been overseas? And so we take a little bit of that history to see if there's exposure. If there is exposure, then, like you say, it's a very kind of careful set of questions. What we're looking for is, has anybody in the house or anybody in your social life had similar symptoms? Has this had a sudden onset? And this is very distinctive of influenza. Very sudden onset to the extent where the patient can tell you at 2 o'clock on Friday, I got sick. I mean, they know exactly what, because it's just bam.
It just slams them. And do all the symptoms kind of hit us at once?
Not exactly.
Okay.
The initial symptoms would be fever, cough, and headache. Usually that's what we see. So that's what we ask.
Yeah.
And fever can't be a subjective fever. It can't be somebody saying, well, I feel feverish. That doesn't count. We're talking about a thermometer.
Yeah.
Right. So they almost always should have fever. They should usually have headaches. They usually have a non-productive cough. They're not coughing up a lot of stuff. They're just coughing.
Okay.
But then pretty quickly they get sore muscles, they get sore all over, they get really achy. They get a lot of what we call malaise, which is, man, I just feel bad.
I feel crummy.
Yeah, I feel bad. But that is a sort of a rapid onset scenario that is pretty distinctive. There are things that you shouldn't have. Usually there aren't a lot of intestinal symptoms.
Okay.
So somebody who is throwing up or maybe has diarrhea, that's probably not it. Now, that doesn't mean they're not sick, and it doesn't mean it's not a virus, but it's probably not influenza.
Well, and I was going to ask about that because we've all talked about the stomach flu. Is there even such an animal, or is that some other digestive problem?
So that's not influenza.
Okay.
But it can be a virus. It can be what we would call viral gastroenteritis.
Okay.
But for example, also with the sore throats and the sniffles, gosh, Mike, there are probably 40 to 50 different viruses that do that.
Okay.
And that doesn't mean you're not sick or you don't feel bad. But that's not influenza. I mean, influenza is pretty dramatic, pretty systemic. And as a doctor, you can almost look at somebody and say, he's got influenza.
Oh, really?
I mean, they're sick people. So you want to know, do they have the exposure? Is it in your area? Do they have the right symptoms? And then if you put that set of facts together, your sensitivity for being right approaches 80%. So then you don't need the test. And the test is a little bit problematic because sometimes it can take that test several days to come back.
By that time, you're getting sicker and sicker and sicker.
Well, yes, and you've lost your opportunity to intervene. And so there are medicines, and this is new in my career, there are medicines now that we can give somebody with influenza.
Oh, really?
Sure. One is called Tamiflu.
Okay, I've heard of that.
And that can be effective in terms of the severity of the illness, the duration of the illness. But Tamiflu really has to be prescribed within the first 48 hours of onset of symptoms.
Oh, okay.
So let's say on a Monday you get this sudden onset, feel bad, you get through Monday night, and on Tuesday you go, I really need to see somebody.
Yeah.
If you don't get medicine by Tuesday night, it's not going to help you.
It's not going to help.
So you've got that 48-hour window, and if we do a nasal swab or a throat swab or some other swab, and
5 days go by,
then what have we proved?
Why did we test?
Right. So we usually don't do a lot of swabbing, and there is no blood test.
Okay.
So it's clinical judgment.
And beyond the drugs that we can now take, isn't it basically you kind of have to let it run its course and kind of defeat the symptoms, or do we cure the flu?
Well, we don't cure it. We can help with the Tamiflu and the meds, but basically the patient is going to have to rest, have to get fluids, probably have to modify diet, probably take some Tylenol, and probably tough it out. The normal course of an influenza infection is about 5 to 7 days.
Okay.
So about 5 to 7 days. Now, the first 2 to 3 of those days, there's a lot of viral shedding. So in terms of somebody being infectious to another family member or a coworker, it's the first 2 to 3 days. So during the flu season, we really try to keep patients out of the workplace.
Oh, sure.
Yeah, absolutely. We do, and if they come in the office, we put masks on them, wash hands, put them in a room we kind of dedicate toward that.
It seems like just the past couple of years in particular, there's been a lot more talk about that. It's if you feel like you've got the flu, stay home. You're not going to do anybody any good except make everybody at the office sick who wouldn't get sick if you didn't go to work.
That is so true. That is so true.
And the same thing goes with children and going to school. Because I can imagine a kindergarten classroom being a nightmare for influenza.
Oh, right. It becomes an incubation dish, a petri dish. And then you have grandparents and parents and brothers and sisters. And pretty soon you have 45,000 people in Calaveras County that are all infected.
That all have the flu.
So really, both for yourself and for the community, you really need to stay home.
Now, the other thing we hear about flu is mortality. I mean, it literally does kill people.
It does kill people.
And what we've been talking about so far doesn't sound like something that's going to take your life. So at what point do we get to where, well, I know it's going to, or it could, but where I was going with that is, I've got the flu again. But at what point does it become worrisome that does it suddenly get more serious, or?
So the people that are the most vulnerable for mortality with influenza are the older people, because they have less reserve, and our very youngest patients are the infants.
Oh, okay.
For the same reason. So the mortality rates tend to be highest in the older and the very young.
Kind of the opposite ends of the age spectrum.
Yes. And mortality is real. It used to be described as about 36,000 deaths per year. Man, that's a lot.
Which is, it sounds like too many to me for something as, like I said, as a layman, simple as the flu. But that's a lot of people.
That is a lot of people. And usually the mechanism of that is a respiratory mechanism. So influenza is a respiratory infection that kind of infects the whole body. But that respiratory infection can turn into a pneumonia. And the pneumonia can either be from the virus itself, from the influenza virus itself, or it can also be what we call a secondary infection. And I don't want to get too complicated with this, but you can have influenza and you go through your 4 to 5 days, you start to get better, you think, I'm turning the corner, and then it comes back. And it actually doesn't come back. What happens is a bacteria gets in there. You're vulnerable. You're sick.
Your system is running on empty.
A bacteria gets in there. We call it strep. There's also staph, streptococcus, staphylococcus, and that bacteria then really goes to town. And that's a common reason for higher mortality rates.
Okay. And the number one, well, aside from washing hands and everything, flu shots. Vaccines.
Right.
Not the easiest subject for some people for some reason. I don't quite understand why, but maybe that's just me. I think there's a lot of fear built into that. But what are because actually just in the past couple of days, I've read that they've changed some of the recommendations with regard to the nasal spray vaccine versus getting shots. And so where do we stand now on who gets a flu shot and when? And
well, it used to be, and this was not too long ago, that it was over 65 and the pediatric age group, and the guys in the middle, like you and me, didn't really need it unless we had certain diseases or vulnerabilities. And more recently, it's been everybody. It's just everybody. So the recommendation is that everybody gets it. It's a good recommendation. It's a good vaccine. It works. But there are things I hear from patients that are really frustrating. For example, one of the most common things I hear is, well, I've never gotten the flu, so I don't need a flu shot. Well, that means absolutely nothing. I mean,
so the one time you get the flu, you're going to really get it, buddy.
Yes, exactly. So that doesn't mean anything. And then often I hear about the side effects, that people feel bad for a day or two.
Or I feel like I got the flu from the flu shot, from the flu vaccine.
And people do have side effects. I mean, the only side effect I've ever had is a sore arm.
A sore spot.
Yeah, a sore spot. But I'm sure people do have more side effects than that. And that's a tough call. You don't want to feel worse, but on the other hand, if you get influenza, you can get really sick, and it's probably worth the risk. So the shots really now are recommended for everybody. They're available now, and there are a couple different kinds. There's a 4-strain called a quadrivalent and a 3-strain called a trivalent. My recommendation would be just get the shot. Don't worry about whether it's the 4 or the 3. Just get the shot.
Because every year they go through and kind of figure out which influenzas are I don't know what the term actually is, but in my layman brain is kind of topping the others and
which strain?
Yeah, which strain is getting stronger, and they kind of go through and figure out which ones that we're going to need to be vaccinated against, right?
Exactly. So these epidemics usually start in the southern hemisphere because they have kind of the opposite winter, right? So during our summer they have winter, and so they get into the southern hemisphere and they figure out what strains are we seeing, and then they isolate those strains. They have names. Sometimes they're named after cities like Bangkok or Singapore or Beijing, but sometimes they just have numbers. But nevertheless, they isolate those strains. Then they develop the vaccine during what our summer is, and the southern hemisphere's winter. Then they isolate the vaccine, they develop the vaccine, and that then becomes available about the October time frame. And it's designed to be the strain that is moving around the world.
I see.
And it's not a perfect system, but it's a pretty good system. The shots are not 100% effective. If we were to give you a shot, we know probably 65% or so will develop antibodies and develop protection. And there's probably 35% that don't.
Oh, really?
Yeah, we're not sure exactly why. Sometimes it's because medications they're on. Sometimes their immune system just doesn't respond. So it's not like 100%. It's not everybody's protected, and it doesn't cover every strain. But they're reasonably effective. And although I am required to have a flu shot every year because I'm a healthcare worker in a hospital, if I wasn't, I'd be getting it every year anyway. Because there just is nothing to lose and everything to gain.
That's what it's sounded like for me. And being diabetic, I usually get one every year. I forgot last year. It just kind of the season just sort of blew by me, and thank goodness I didn't get the flu. But what I want to ask now is, okay, so we get the flu, and we're home. Feed a fever, starve a cold. What are we doing when we're at home? I know we're going to be in bed because we're just, like you say, we've got that malaise. We're feeling absolutely horrible.
Right.
And so you're going to be home resting. It's not time to be splitting wood and
right, or working, or your body. Your body is such a miracle. I mean, it really is. Yeah. It is such a miracle. And it'll heal. It'll fight this infection. It'll heal, but you have to let it do that. Mm-hmm. And so you have to have some nutrition. You have to have some rest. Mm-hmm. You have to kind of, lay in bed and get some fluids. There's a couple things you can do. Rest, honestly, and actually sleep is a good thing. I think those people recover better and quicker. Tylenol helps. Sometimes Aleve, Advil, those kinds of things will help. But there's a real proviso here, and there is a relationship between aspirin and influenza that is a bad relationship.
Oh, okay.
And particularly in our young patients and our children. Mm-hmm. And so if children take aspirin, there is a rare syndrome called Reye syndrome. Mm-hmm. And Reye syndrome can be fatal. It can be very serious. It involves the brain and the central nervous system.
Oh, goodness.
It involves hospitalization. And so the advice is go home, rest, maybe take some Tylenol, get fluids, ride it out, but don't take aspirin.
Okay.
I would say just across the board, don't take aspirin. I mean, it doesn't matter what age you are. I just, it's a bad complication.
And the Tylenol you're taking to help reduce the fever and help with those body and muscle aches?
Exactly. The muscle aches, the headaches can be really serious. I mean, really incapacitating. Mm-hmm. And it doesn't mean your brain is in trouble or you have a brain complication. It's just it's a bad headache. And, Tylenol will help that. And rest will help that. Aleve, Advil in an adult will help that. But those things will help with the pain, help with the headache, help with the fever. Okay. Now, again, if you're quick enough and you're within 48 hours, we can prescribe medications that'll help you. We can prescribe Tamiflu, and that can be very effective. It's available. I don't even believe it's expensive. We just have to know. Mm-hmm. And sometimes I'm willing to do that over the phone.
I was going to ask that, and I could, imagine, that being relatively quick and being beneficial for the other patients in your office who you don't want to expose to the flu. But what I wanted to ask from there is, okay, we've decided we've got the flu, and it's been about 4 days, 5 days, and maybe we thought we were feeling a little better, and then we get to the next Monday, and it's not that we don't want to go to work, it's we're feeling crummy again. Is that where you've got to make an appointment with a doctor?
Probably.
Okay.
Probably.
Because this could be
if you have a clinical course where you get sick, you have influenza, or you're pretty sure you do, you start to get better, you feel better, and then you start to get sick again, we should really see you. Yeah. Because there are things. Actually, the influenza virus can infect your heart, can infect your brain, not the headache scenario, but another scenario. So that virus can go to lots of different organs and cause lots of problems. Now, that's not a common complication. They're uncommon, but in a country with 300 million, we see it. Yeah. We absolutely see it. Mm-hmm. And so in that scenario, I think it's smart to make an appointment or to have contact with a provider.
And would you maybe even, let's say in that first day, make that call to your doctor and say, I think I'm getting the flu. Do I need to come see you? Do you make the call kind of proactively to see what your doctor recommends, or do you maybe try and ride out that first wave?
I think you have to use judgment. I think sick people should always err on the side of seeing somebody and asking them what's wrong. I get nervous about being too cavalier about that because there's so much you learn when you see somebody.
And you
say, okay, he's
sick.
Sick.
Especially if you've seen the number of patients you have, and you can go, oh, he's got the flu.
Or maybe something else. Maybe he's got something else. But I think you should always err on the side. But, people can use judgment. They can say, well, it's a sore throat. It's not influenza. I've got a sore throat. I've got a runny nose. I've got a cold. I'm just going to stay home. I'm perfectly okay with that. But if they have this impressive sudden onset achy headache and they can make contact within 48 hours, man, that's what I would do.
Yeah.
Because actually a couple of years ago I had influenza and I took Tamiflu and I did it because I didn't want to be sick for a long time and I didn't want complications.
Yeah.
So I would try to make the contact. But, one of the other things we really get frustrated with is most of these infections are viral infections. This is my editorial for today.
Sure.
Most of these infections are viral infections. So the sore throat, runny nose, even the influenza, these are viral infections. And patients frequently demand antibiotics. I have to have an antibiotic, and my other doctor gave me antibiotics, and my aunt took antibiotics, and so my job is to say, I've gone over your history, I've looked at everything. This is not a bacterial infection, it's a viral infection, and antibiotics are simply not going to help you.
Don't do anything.
They don't do anything.
Yeah.
About half of the time, I'm effective and persuasive, which is a pretty good day.
Yeah.
And the other half of the time, they say, however, I took antibiotics 2 years ago, and they really helped me, and I want them now, and you're my doctor, and you can't say no. And you say, fine, here's your antibiotics.
So we're down to the last few seconds. So basically, it's wash your hands, keep yourself clean.
Stay out of the public.
Stay out of the public if you feel like you've come down with it.
Get a flu shot.
Get a flu shot right now.
Right now.
They're available at the county health department.
Right now.
And if you can't afford it, you can still get the shot because they won't charge you for it. So, and on that note, Dr. Smart, we're going to have to say that the doctor is out for another month.
Thanks so much, Mike.
Ladies and gentlemen, stay healthy. I'm Mike Taylor, and until next time, be well.